Welcome to Medical Myths, Legends, and Fairy Tales. I'm your host, Dr. Alan Christensen. Look, you know that between the latest online fads and the crazy media headlines, it's easier than ever to get confused about your health. And you and I just want to feel better and live longer. We want to know what works. And we can't wait for further studies. We need to make decisions today based on the best evidence we've got. Well, that's exactly what this show is here for. So let's get to it.
Hi there, this is Dr. Linda Kashaba from Integrative Health. Would you like some help with your thyroid? We would absolutely love to help you out. And guess what? We can even do remote care. Please call us today at 480-657-0003 to set up your first appointment. If you mention code podcast20, you will get 20% off from your first visit. That phone number again is 480-657-0003, and the code is podcast20. Can't wait to meet you.
Hey, Dr. C here, and welcome back to another episode of Medical Myths, Legends, and Fairy Tales. So, if your snot is green, do you need an antibiotic? I had a really fun discussion with a dear friend and my checkup general health doctor, Dr. Susan Wilder. We met many years ago. She first saw me, she's public about that, as a patient for her own health, her own hormone needs. And we've just become friends over the years. And so, I go to see her and love to have objective input on my own health. And she's the gal for that and just wonderful in family practice. She founded Lifescape Premier. She trained in family medicine in the Air Force. And she also then founded the Mayo Clinic's family medicine residency before she founded her practice Lifescape back in 2003. She is the gal for general practice, family medicine, adult care. And we had a real good discussion about all things infectious disease, antibiotics. One thing that really jumped out was I see many people write in that are struggling with recurrent bladder infections. And we talked about how many of those are things that honestly don't even warrant treatment. If people are on antibiotics they don't need for it. We talked a bit about vaccinations. We covered a lot of ground on many low-grade infections, whether or not autoimmunity is served by eradicating all these little bugs that are lurking, or whether you're better off to have a little bit of immune challenge. So fun conversation. I learned some cool things and hope you enjoy Dr. Susan Wilder. Hey, Susie's with us, so awesome. Let's do this thing. How you doing this morning?
I am doing great, Alan.
Well, great to have some more time with you. Just saw you here a couple weeks back, and this is going to be a lot of fun. So there's a lot of confusion, I think, about antibiotics. And I think there's times in which the consumer, I think more often than not, often ends up overusing them. And people think, well, I don't want to take them. But then they're sick for a week and they're like, oh, this has to go away. And they do anyway. So let's talk through. And for starters, let's talk about just what are the pitfalls about using them if you don't need them at all? Like, what's the drawback about overprescribing?
Well, the more we're understanding about our microbiome, the trillions of bacteria that reside all over the body, but predominantly in our intestines and our gut, the microbiome is essentially the heart of our immune system. It dictates a huge percentage of how we clear toxins, how we produce hormones, whether our genes get activated or not, how well we produce neurochemicals and our brains function. And so, when we use antibiotics or consume them from our food supply or exposed to them and even topically, we're nuking some really important cohabitants of our body, and we can't survive without a healthy microbiome. And we know that just one course of antibiotics can knock out a lot of healthy bacteria for upwards of 4 to even 12 months.
Wow.
And if you repeated courses, you can permanently impair your microbiome. So it is not without harm.
I've seen some data like that. It's kind of scary stuff suggesting that enough of a trauma that they're seeing that even long-term, it may not come back all the way.
Exactly. I mean, we know, just if you start off life via C-section versus a vaginal delivery, your microbiome is set up very differently. So we're learning more and more, and you and my naturopathic colleagues and students that I've trained over the years have always taught me the gut is the heart, of the body, and that, first heal the gut. Well, again, the more detail we're learning about, these bacteria, and it's not just our gut, it's the microbiome in your oral cavity. If you use antibacterial mouthwashes, you nuke bacteria that are important for nitric oxide production, and you increase your risk of high blood pressure, cardiovascular disease, and even prediabetes just by using an antibacterial mouthwash.
And that was fascinating. You mentioned that about nitrous oxide production. It's kind of funny. We hear about foods like beets or whatnot, and people often don't realize that a lot of that magic is going on inside the mouth.
Right. That oral microbiome is important. The active chewing is important to your brain's blood flow. So many different factors. One of my patients the other day, wanted absolute certainty about exactly what probiotics she should be taking and what she should be eating every single day. And I said, I can't tell you that. No one can tell you that. We need diversity, and we need to consume mostly healthy things, obviously, very plant-based and more fiber, and less of the processed, refined things that don't support a healthy microbiome.
So walk us through a classic scenario in which someone may end up being on an antibiotic that they never really needed.
Oh gosh, there are so so common, and I think we're getting a little bit better, but I think the myths are, number one, if it's green, whether we're talking snot or sputum, if it's green, it needs an antibiotic. That is false. And
there's not a color test, huh?
There's not a color test, and in fact, I watched my kids. When my 3 kids were young. Every viral infection they had went through a green snot stage. There just a normal part of those white cells kicking in and fighting off this infection that'll show up. And especially what you cough up or blow out of your nose first thing in the morning has been sitting there all night long. And it's always going to be a little discolored. So I don't ever worry about the first thing in the morning, how things look. It's when you're persistently coughing up a lot of purulent sputum or and have had symptoms that have lasted over 10 days, then you really might need an antibiotic.
Another fun tip for people out there is you don't actually have to save that to show the doctor the color. It's okay to
Right, exactly. Oh, I've had people bring in a week worth of sputum. That's always nice right before lunch.
Not necessary. You don't have to do that. So some will think, yeah, if it's been a long time, the duration. So what are your thoughts about the duration being relative to that risk?
Well, it's such a tough call, I think. What I always am wishing for is that these rapid tests for respiratory pathogens become cost effective enough and quick enough that we can use them to prove to people that this is viral, not bacterial, because might be allergic. A lot of patients recurring or protracted symptoms are really allergic. But the fact of the matter is, upwards of 50 to 80% of sore throats, nearly 100% of laryngitis, over 90% of bronchitis and sinusitis are viral infections. So if they go through that kind of normal process or they hit multiple sites, viruses hit everything. They're just kind of like a shotgun. So you'll get throat symptoms, you'll get congestive symptoms, maybe sneezing, you'll get respiratory symptoms, cough, etc. Whereas bacterial symptoms tend to be very focused in one site. They will hit directly to your sinuses or directly to your throat and not anywhere else. And usually with fever and kind of more significant symptoms. We used to think, well, if it lasts 10 days or more, it's a little more likely to be bacterial. And I think that's true to a point. But I look more at the big picture. What's the patient's immune system like? How is this disease progressing? If it's just kind of a chronic hacking cough that's hanging on, that may hang on for a few weeks. And there's a lot of less harmful strategies we could deploy to help with that rather than throwing an antibiotic at it. If, though, the patient's kind of gone through sort of the normal viral symptoms, seem to be getting better, and that gets suddenly re-sick, with fever or chills or a very productive cough or something like that, that clues me into this may be a bacterial secondary infection.
I loved your comments about the localized versus all over, and that there's something that I learned that I thought was useful, and it sounds like what you're saying validates that. That I thought about respiratory infections like four compartments, like your sinuses, your throat, your lungs, and your ears. And the more areas you have symptoms, so if you got the runny nose and the cough and the sore throat, and the more areas you've got symptoms going on, the more likely it is to be viral. And the
Correct.
cases where it's really localized to one of those four, then some, not always, but then that's a more probable scenario for being consideration for being bacterial.
Exactly. No, I agree entirely.
So duration, not as strong, but localized is a stronger indicator, and then coming back, so symptomatic, running a course, and then relapsing again. You mentioned.
Mm-hmm. Yeah. And then, another myth is that we need to eradicate all bacteria. I think a lot of our medication overuse and our overly clean lifestyles, which are contributing, now we understand, to a lot of autoimmune diseases that don't exist in less hygienic cultures. Um, it's just wrong. There are times where bacterial colonization is not harmful. There are many elderly adults, particularly women, who have chronic culture positive urine cultures, and where they have bacteria that are just living there, but they don't have white blood cells showing up in the urinalysis. And I was just talking yesterday with Dr. Dalal, who runs Arizona Infectious Disease, and he works out of our office. And he was saying, look, if there's no white blood cells in the urine, that colonization is not causing an actual pathogenic infection and doesn't need to be treated. So I think a lot of unnecessary antibiotics are because we uncovered something. We uncovered H. pylori. Well, hey, research is now showing there are some beneficial things to H. pylori. There may be conceivably a reason why that colonization has taken place. And we don't always know whether eradication of that agent is a good thing or a bad thing.
If you're taking the person to better long-term health, I've seen data arguing that similar populations with H. pylori may have lower rates of colorectal cancer than populations that don't.
Exactly. So there, you and I have been in medicine,
A long time.
right? It's kind of scary when, the babies I delivered are now in medical school. But the more, I don't know how you feel, but the longer I've been in medicine, the more I know, the more I realize how little we know. It's very humbling, right? It's like, oh my gosh. And, now I'm dealing with all these patients where we're culturing these highly resistant bacteria from their nasopharynx or marcons or staph variants. And 80% of us have staph colonizing our nasal cavities. What I haven't seen yet, and I'm not really sure about, is whether taking aggressive steps to try to clear these colonizations helps more than it harms.
That's awesome. And that's so big in the thyroid space. There's talk about just the fear about chronic infections being a driver. You talked about the whole hygiene theory of immune system health. I've seen a lot of data about autoimmunity arguing that, early life and even perhaps ongoing infections are preventers. They're good things for lessening the risk of autoimmunity. And I see many that would get very worked up about H. pylori or blastocystis or things that we're not always sure if they're really infections or they're along for the ride. And that's the question is aggressively going after these things bringing someone to better health?
Right. I think it's a really tough dilemma for us because we can identify so much more now, but that doesn't necessarily mean it needs to be targeted. It's a symptom like everything else, and we just need to look at that in context. I have a patient who has she's quite healthy, and but somehow did some testing and identified a bunch of mold toxins and has gone through hell and back and spent a ton of money treating mold toxin illness when she didn't have any symptoms of mold toxicity. So,
Wow.
it's a really tough, it's a tough arena. And could she have developed symptoms? I don't know. Prevention is such a challenge. How do I prove that I headed off somebody from having a heart attack or a cancer or a neurologic consequence of something that I uncovered? Or did I harm them by uncovering something that really wasn't ever clinically an issue?
Yeah. It's such a great point you bring up, and I think that many of our audience are at the place now to where they are getting exposed to more elective medicine, and in that world, there is an incentivization towards finding things and seeming to have solutions. But it reminds me back another thing back in the early days for us is when they had the MRI and the CT devices. Like what was the Ameriscan? That's right. When they were in the big malls, and you could just go in there and
Oh, yeah.
electrically get your whole body imaged. That's actually coming back, I've seen. But the
Well,
pitfall go ahead.
I will sadly admit that I was working with a company um, that does exactly that. Well, they were talking to me about potentially doing some consulting for them, and they do MRI imaging and map your whole genome. And intuitively, I said, I think the imaging is bad medicine, and I think the mapping the genome is not particularly helpful because I've got these 22,000 genes in my genome, and I got a trillion in my gut that dictate whether any of those get activated or not. So I think the gut is more important. But they offered a free assessment, of course. So I put my husband through it. So it's a terrible thing to be a family member of a physician because you just become a guinea pig for everything, and God bless it. And it actually proved that theory, and ended up with a bunch of tail chasing things and
Yeah.
not much that was useful. And really, the tail chasing is harmful. It's not better.
The Ameriscans, that was where they went by the wayside, was that people had so many findings that were not clinically relevant, but they had to pursue them, and it was
Right.
found to be not being useful to better health outcomes. It was just more unnecessary procedures, and all these things were being done that,
Oh.
yeah,
Well, I look at, we talked about thyroid disease, and
yeah,
you're my thyroid expert. But, if you look at the mortality risk from thyroid cancer over the entire spectrum of the 30 plus years I've been in medicine, that hasn't budged. Yet we are imaging and biopsying more thyroids than we have ever done. So, just at a huge, exponential increase in the interventions we are deploying, yet we have not changed that mortality risk.
hmm
So how good are all those interventions? I really have to question it.
And that's the cool thing. And so I wanted to have you talk and just share some perspective like that. So you mentioned a few symptoms that were not as differentiating. So how about fever? Is that a useful thing in terms of viral versus bacterial? Or
Yeah, fever can be a very useful symptom. Certainly, high fevers tend to be more common with bacterial infections, whereas low grade, under maybe 100.5 Fahrenheit, would be more likely to indicate a viral infection. Although, highest fever I ever had was when I had influenza a couple of years ago, and thought I was going to die. I think in some ways, viral infections are a little bit worse just because they can hit everything. Really hit your entire body. And with flu, I even said to my husband, my eyelashes hurt.
your eyelashes.
Like everything. My sister came over with some homemade chicken soup and a bottle of brandy. And my husband goes, she won't drink that. And my daughter goes, oh, yes, she will. It was like whatever works. And a little raw honey and brandy heated up. Yeah, that would work like a charm. I'm not going to describe it, but hey, whatever works.
We'll be right back after word from Integrative Health.
We hope you are enjoying this episode of Medical Myths, Legends, and Fairy Tale. This is Dr. Roz at Integrative Healthcare. You know, so often we hear from our patients that their primary care physician has told them that their thyroid and hormone levels are fine and they should not worry. Yet the patients still have symptoms of severe fatigue, thinning hair, and weight issues. Unfortunately, this is too common with thyroid care. The good news is we can help and there is hope. The doctors at Integrative Healthcare, including myself, specialize in naturally treated thyroid, hormones, and adrenal issues. We would love to get you started on the path to ideal health. From the comfort of your own home, we can get treatment from one of the doctors at Integrative Health via telemedicine. Go to integrativehealthcare.com to become a new patient today. Use code PODCAST20 for 20% off of your new patient visit. Again, this is integrativehealthcare.com. Use code PODCAST20. Get back on the road to thriving.
And now, back for more medical myths, legends, and fairy tales. So, then we have to question whether or not the interventions are helpful. So, influenza and Tamiflu, or sinus infections and antibiotics. So let's talk about those things a little bit.
Sure. I mean, yeah, the antiviral medicines are of marginal benefit. So Tamiflu will shorten the duration of influenza by less than a day, so maybe 14 hours shorter. The newer agent, Xofluza, which halts viral reproduction, still doesn't shorten the course that dramatically longer than Tamiflu, but I think has a lot more promise in preventing others from catching the flu, and potentially, although it's too early to have really good data, or dramatically reducing the risk of complications and death.
And aren't those agents conditional upon like almost instantaneous diagnosis? Like if you're starting them at the very earliest stages?
Right. Tamiflu, you want to start these within 48 hours of symptoms to have any benefit at all. Where I think they're most helpful, though, is preventive treatment for close contacts. Because, we forget, I think American culture has gone a little bit to a every man for himself mindset of, well, I'm going to do what's good for me and my family, and I'm not going to worry about anybody else. But with things like influenza, with things like measles, with, that are highly, highly infectious, even hepatitis, some of those infections that right now are flaring again. We need to think all for one, one for all. We have a lot of very vulnerable people in our population. And honestly, I could not live with myself if, I chose to not vaccinate my kids and their asthmatic friend died of flu, or their friend's mom who's on chemo for breast cancer, or their pregnant teacher, or their elderly grandparent. We're not being thoughtful about the other people in our exposome. And I look at my own staff, when we started in medicine, we saw very few autoimmune disorders and on immune reducing medications or immune suppressing medications. Now, half my staff have autoimmune disorders and many immune suppressing medication, and many in our exposure world their immune systems are not normal. Now, these are the same people that we have to be cautious about vaccinating because you want to have a healthy immune system. You don't want to be an inflammatory mess and get a bunch of vaccines. That's where I think some of the hazards of vaccines are occurring. We're not being careful about our patient selection and getting their inflammation under control and their guts healthy before we start, throwing in these immune triggers or immune stimulants that we want to prime their system.
That's an awesome point. The decisions we're making in the case of managing infections are not personal decisions. And as a society, we've realized that, we don't validate, we don't respect the ability to make personal decisions when it comes to things like a blood alcohol level. I can't say, well, I can actually do fine if I drink 6 beers. I'm better than average. I can't legally say that. I still have to go by the same guidelines. And then
Right.
think about like non-communicable disease. Just imagine a crazy scenario. Imagine that diabetes were contagious. And imagine that I was sitting next to you in your cubicle, and we shared a cubicle in the office, and I was eating 12 packs of donuts every morning. You'd be pissed. Like, hey, you're going to give me diabetes. And that's silly, but that wouldn't be okay. That wouldn't be all right for me to do that if I was going to create a risk for you by my choices.
Right.
So it's
Right.
not different for infectious disease.
No, I think we just need to be a little bit more thoughtful about that. And I think that anytime we try to couch things as all good or all bad, we're usually wrong. I mean, there are a few things like, I don't know, nerve toxins are probably all bad, but I don't, I mean, there are, and vaccines are phenomenally helpful. I mean, I have patients who survived polio, and my parents, my sister went to nursing school right in the midst of a rubella epidemic, and every single baby was deformed. She
Wow.
would be a labor and delivery nurse, but she couldn't do it. I have seen a healthy 16-year-old football player drop dead within
Oh,
30
geez.
minutes of meningococcal meningitis.
Oh, wow.
Things we never see anymore, thank God. I have lived through, measles outbreaks, and it is terrifying how highly infectious some of these things are. And these people are sick when they get it. And guess what? I just tested non-immune to measles, which is a
Oh,
shock.
wow.
But, if you're born between 1957 and 1968, you might have gotten a vaccine. Your initial vaccines were not as effective. And so it's worth getting a titer to know, are you at risk? Are you going to put your grandchildren at risk, or what have you?
Wow.
Pregnant loved one.
It's
So
pretty.
I think we have to be thoughtful about the big picture. And so when I, counsel families about vaccination, and of course they're reading so much online, and, I am so grateful that you're doing this kind of educational podcast, because what we're understanding about the Russian bots and now the Chinese bots working together to divide the American public, they are delving into healthcare, because
Oh, my goodness.
as really divisive arenas to continue driving a wedge in the American public. And so we need to have fact-checking, trusted resources who are really doing their best to truly get the truth out there, because there is so much scary misinformation being passed around. But I counsel families that, look, we can take vaccines more slowly. There are some I don't really care about until later, because we have herd immunity protecting us. So we can be free riders for polio right now for a period of time. But if you're going to travel at all, if you're going to get on a plane with that child, then I want to make sure they're going to be vaccinated for the things they're most likely to come in contact with, or the things that are the most lethal. It would be devastating to me if any of the kids that we take care of died of something that was vaccine preventable, particularly the meningitis bugs.
Well, and the things that we could get on a plane and travel to, they can also travel to us.
Right. Absolutely. I mean,
Planes go both ways.
Somebody could be in an elevator hours before you.
Yeah.
Ride at Disneyland or whatever, and you pick up, things like measles. That could last a long time.
pretty wild thing, but I did a couple of episodes for this podcast on vaccination, and there's a community in my profession that's highly supportive of vaccines and very evidence based. And I talked to a good representative there. I wanted to separately speak to someone who would represent the other side, just to like talk through some of their arguments. And it's pretty wild. The six biggest names in that movement all lined up and were eager to speak with me, and they all backed down in the last, like, the 11th hour. And right now they're under such scrutiny. And I thought about that, and I struggled at first thinking, it's almost too bad that people can't speak freely. But then I realized there's some kind of free speech that, you can't yell fire in a theater. There's some kinds of free speech that are just inherently harmful that we've decided we're better off not having.
Yeah. Well, and I think, my husband and I were talking about this last night, that, that even the newspapers' opinion pieces ought to be fact checked, because there are people allowed to spout their opinions where there are clearly well-defined facts, but somebody once said, you can't fight faith with facts.
Well, and you can't fight fear with facts. That's the other asymmetry I realized, is that if someone is doing things that are driving up fear, then no matter how good the facts are, it's not a fair fight. It's completely asymmetrical, and a message that's fearful.
That's what these Russian and Chinese bots are really trying to capitalize on, is fear and anger, and let's drive a wedge in the American
outrage
and destroy democracy. So to me, we need the hashtag I'm not buying it.
Hashtag I'm not buying it.
Right? I mean, we fact check everything, and then respond respectfully and thoughtfully, but respond and say, hey, fact check this, and sorry, that's not true, and please stop spreading it. We need to hold each other accountable and hold ourselves accountable. I am very gullible. My husband had me believe, out of all the football bowl games, that there was a rutabaga bowl. I can be sold.
I wouldn't have known.
I can be sold just about anything, but he is like the perpetual pessimist. I tell him his job description is wet blanket, but it's really great to have somebody that who is really good at digging into the research and finding valuable sources. But so much of what is being sent to us in our media feeds is garbage, and we need to chuck it and stick to sources that are trustworthy and are willing to fact check it.
I want to expand briefly on one prior point. I just want to make sure the listeners really heard that about urinary tract infections, because I think that there's many, many listeners who are out there that have been in that cycle, to where they keep having this seeming, measurable infection per urinalysis, but not necessarily symptomatic. And they keep going through cycles of antibiotics for that. And you're saying that in many cases, the treatment's not necessary.
Right. I mean, if they're having symptoms, that's one thing. But if you're just culturing out a positive bug and no white cells in the urine, so no inflammatory response from your immune system, that's a colonization. It's not an infection. And you'd be better served doing something, one, hydrating, clearing toxins from your body, doing things to support your immune system, and avoiding bladder irritants to keep the bladder functioning normally. So, really acidic foods and caffeine and alcohol. Alcohol, alcohol, I think it does not get enough press in healthcare as
I'm with you.
a toxin. It's a whole nother area, but it's an immune, it's a carcinogen, and it's an immune toxin as well, and a neurotoxin. I mean, the reason we like it, it's because it's a neurotoxin. Dims the lights a little bit and dims our inhibitions. But I think a lot of people are consuming way more than they should, and that affects your bladder, that affects your heart, it affects your gut. I had a patient come in for her physical hungover from an event the night before, and it was
Oh, geez.
a cancer cancer fundraiser.
Oh, no.
So does the irony strike you as kind of funny that you overdosed on a carcinogen at a cancer
Oh, geez.
fundraiser? But and again, alcohol-containing mouthwashes, that is a carcinogen in your mouth.
Wow.
Crazy.
So let's say someone has had, it wasn't just the green sputum, they really did have a positive strep throat. It was localized. They were intensely sick for that. It was persistent. They need an antibiotic for some reason. So what are some best practices you suggest to mitigate any harm from that?
So first and most important is the right antibiotic for that particular type of infection. So you want to have an antibiotic that it covers the most likely bugs or the bug, and not more than that. You don't need a shotgun to, hit something that you've got to target. You can do a beep.
Not everything needs ciprofloxacin, huh?
Oh gosh, yeah, quinones are probably one of the last ones we want to use. So right antibiotic. I was very, very fortunate in residency to have an infectious disease doctor as my mentor. So I really had this drilled in. Number two is you need a high enough dose, but a short duration of action. And a lot of studies are very clear on how many days we should be treating a lot of these infections. So we don't always need to treat everything for 10 days. Many infections we can do well with a higher dose, but 5-day duration. And then patients need to complete their antibiotics.
But what if they're feeling better?
I know they always are. But if you've not completed the antibiotic, you have the risk of selecting out more resistant bacteria. So that may come back to bite you in the future. I just had a patient come back with who immune system is a mess from many decades of smoking, and before that alcohol and smoking. And so, but came back with a urine culture resistant to just about everything.
Oh, wow.
We're entering what's called the post-antibiotic era where, some of these bugs, we have no weapon for them. And that is very scary.
Yeah. And there's none in the pipeline, right?
None in the pipeline. Yeah. And then from speaking to my infectious disease colleague, Dr. Dalal, yesterday, he said the same thing. The right drug for the bug and the right dose, high enough dose, and the shortest appropriate duration.
And what are your guidelines on probiotics with antibiotics, after antibiotics, particular ones?
Yeah, there is so much data out there. I'm sure you've read a ton of it. It's pretty overwhelming, but I think there's reasonable benefit and very minimum of harm in using a couple of specific probiotics. Number one, Saccharomyces boulardii, to counteract, sort of the candida yeast overgrowth that tends to happen when we nuke the microbiome a bit. Also, some of the lactobacillus species, rhamnosus and reuteri. So I usually do prescribe a good dose lactobacillus probiotic and Saccharomyces boulardii while people are on antibiotics and for at least a month afterwards. I don't have great data that rapidly repopulates the gut microbiome. In fact, I got to meet Justin and Erica Sonnenberg, who wrote the book, The Good Gut, and they're microbiome researchers at Stanford. And they actually, their research is not finding that oral probiotics are particularly showing great outcomes in actual microbiome shifting. But they've, found that fermented foods, particularly kefir and kombucha, do.
And prebiotics.
Yeah, I mean, again, food first. Food is always better. We keep forgetting that, but yeah, fermented foods come with the prebiotics and the probiotics. They're truly symbiotics. Now do see, I had a guy have a horrific reaction from just overdosing on, I can't remember what it was, but something like kimchi or, some fermented vegetables. But you only need a couple tablespoons a day. If you're doing a cup of it, it's not good. I used to tell patients you can never overdose on vegetables. Well, I had a patient eat a huge bowl of Brussels sprouts, ended up obstructing his small intestine, and a horrific surgery, horrific wound complication, $1 million hospitalization because he
Oh, wow.
on Brussels sprouts. So
But was that just the food volume? I mean, that was
it was just that much fiber, and that it was just, yeah. We, as my daughter used to say when she was little, once at first you don't exceed, try again. That is America in a nutshell. And it just was actually, I met the Sonnenbergs at a culinary medicine course that Harvard does out in Napa, and there's a big culinary museum at the Culinary Institute of America there. And one of the things I noticed walking around this museum that has all this kitchenware, glassware, tableware, wine paraphernalia is that everything is tiny. There was no wine glass over 3 ounces. There was not a coffee cup over 5 ounces. There was not a plate that was larger than a salad plate. Everything was tiny. And we have supersized everything, including Americans. I went out to dinner that same night and could not get my hand around the wine glass I was served. And you wonder why we're in the space range. People, and we know even things like acid reflux, 85% of acid reflux is resolved by the ELF diet. Eat less food. It's a volume problem,
That's wild. And then reflex also just timing for people, like how late that is, how quickly they're lying down after eating. And
yeah, so we do a huge meal, a bunch of wine and then coffee, loosen up that nice lower esophageal sphincter, and then go lay down. I wonder why you have acid reflux. Yeah, got to love your disease, America.
So infectious disease, antibiotics, we spoke just a bit before we started recording, and you're doing a program right now about training people on how to effectively prepare for surgery and recover afterwards. It's a total tie-in. I'd love for you to talk a little bit about some things that you're going to be mentioning with that, and we can give people some access to learning about it as well. So yeah, what are you up to that way?
Well, yeah, I was inspired to create this program because of patients like the one I just mentioned. And honestly, I lost my father-in-law to really poor preparation prior to heart surgery. They
no.
do appropriate lung testing and understand his lung volumes. He was this very small man, and they and this was at one of the best medical centers in the country, and they set a ventilator setting for a normal larger man and blew out both his lungs. And
oh my goodness,
one complication after the other, a lot of medication mismanagement, and eventually, a 6-month hospitalization, and then he passed away. So
wow.
That really knocked me. And so, I realized, look, surgery is the biggest athletic event of our lives, and we're not training for it. Patients go in, they go through a preoperative clearance that is pretty much useless.
Basic EKG and CBC,
right.
And that's about it.
Never proven to reduce your risk of complications. And the surgeons and their team will, review the possible risks with you, but nobody's getting you in shape for surgery, mentally, physically, emotionally. I had a horrific surgical complication when I was a residency director at Mayo, and had surgery for a skin cancer on my eyelid, and it ended up being 4 hours. And honestly, I lost IQ points that I never got back, and I can't afford that. But I came to understand that I had genetic issues in how I process certain medications. And one of my daughters has the same thing, and she just had surgery and she had some significant harm from a scopolamine patch, a little motion sickness patch that they stuck on her the night before surgery. I could not get a hold of her at 11:30 the next day. It knocked her out completely for 13 and a half hours.
Wow.
And they hadn't done the pre-op clearance that they need to do. So there's so much that we can do as consumers, as patients, to be warriors rather than passive victims. And that's what my program is about.
That's really cool. We're going to have some links to that in the show notes, and I'll talk more about that as it's more mature and share that with the audience, but that'll be super helpful. So Susie, Dr. Susan Wilder, thank you so much for your time. This has been really great stuff.
Well, it's always fun to chat with you, Ellen. And, I think what you're doing is really valuable. So thank you.
All right. Sounds good. Everyone out there, take great care. I'll be back with you real soon. Bye-bye. Hey, Dr. Christensen here. Thanks so much for joining me for another episode. Is there a topic you'd like me to cover? I'd love to hear from you. Just go to Dr. Alan Christensen on Facebook or Instagram, write your question, and use the hashtag #MedicalMyths. Did you find this show helpful? If so, please take a minute and leave us a rating on iTunes so that others can know. Thanks much. I'll be back with you real soon. Bye-bye.